Critically ill patients may be prescribed as many as 20 to 30 medications, which increases the risk of drug-drug interactions that may lead to serious adverse outcomes, such as mortality and readmission. Our team DIGNIF.AI has taken up the challenge of discovering drug-drug interactions in ICU patients by using a novel application of graph neural networks and causal inference. It is a major clinical challenge to identify DDIs in ICU patients. Conventionally, DDIs are identified by knowledge of pharmacology and drug mechanisms, pre-market reporting from clinical trials, and ad hoc post-market reporting by clinicians. However, in ICU patients, conventional pharmacologic mechanisms may not apply due to organ dysfunction. Critically ill patients are also not well represented in clinical trials, and post-marketing surveillance may fail to distinguish adverse events due to DDIs from the patient's underlying diseases. Additionally, there are technical challenges in discovering DDIs from drug administration data. Medication lists are not static, and so an ideal solution would need to capture the timing of drug dosing, allow for interpretation of drug interactions without pre-specified hypotheses, and have flexibility for multi-way drug interactions. This is inadequately addressed by historic techniques, such as regression models, which often oversimplify the time dimension by one-hot encoding drugs. While interaction terms can be specified, long drug lists require multiple hypothesis testing, which needs further statistical correction. More modern techniques have represented drug administration times as sequences, and use techniques such as transformers to encode the information. These methods can produce accurate predictions of adverse outcomes, but it is difficult to interpret and extract the underlying DDI. For this datathon, we focus on DDIs causing acute kidney injury occurring within 48 hours of ICU admission in ICU patients from the MIMIC-4 cohort. We made use of the electronic medicine administration records from 1 day before and 1 day after ICU admission, as well as relevant covariates such as age, gender, vital signs, and laboratory tests. We had a two-step aim. First, to build an accurate model for AKI prediction by using a graph to represent the temporal drug administration inputs and other covariates. Second, to discover DDIs through average treatment effect on the treated, or ATET analysis of different drug combinations. Our base cohort had approximately 21,000 ICU admissions, of which around 11,000 or 51% developed AKI. For this datathon, we considered 377 drugs grouped into 89 drug categories. Pre-processing including normalization was done for the other covariates, and we used a 70-30 train test split. To predict AKI, we first constructed a heterograph consisting of a subgraph for drug administration, a subgraph for each covariate type, and a subgraph for the outcome of AKI. Temporal embedding was used for the timestamp features. The main task of the graph neural network was to predict the presence of a link between a given patient node and the AKI outcome node. With the trained GNN model, we estimated the ATET for each pair of drug categories in the subcohort that they were co-administered in. We defined a pair of drugs to have a DDI if the average AKI risk when the drugs are co-administered is higher than the average risk of the drugs being administered in isolation. Our results showed that the graph neural network model achieved excellent performance in AKI risk prediction with an AURC of 0.855 and an AUPRC of 0.876. This performance is comparable to the published literature. We confirmed the presence of known DDIs such as cyclosporin and statins, which have been reported in isolated case studies so far. We also identified novel DDIs such as macrolide antibiotics with nitrates and loop diuretics, as well as statins with tacrolimus and carbapenems. This was unexpected as these drugs are conventionally not associated with AKI, and statins are thought to be protective for AKI. We also discovered unexpected drug interactions that reduce the risk of AKI, such as ACE inhibitors with other drugs. While ACE inhibitors may cause AKI when acutely administered, it may be that patients already on ACE inhibitors are protected from AKI. These DDIs warrant further investigation. In this datathon, we built an accurate graph neural network model for AKI prediction and applied causal inference on top of this model to confirm known DDIs and discover potentially novel DDIs. Our current graph model was abbreviated to decrease computational complexity. We intentionally collapsed individual drugs into broader drug categories, and hence we were unable to include drug dosing information as different drugs were grouped together. We also restricted the number of covariates to focus on the task of DDI modeling and discovery, and our outcome was a modified AKI definition focusing on short-term prediction. Future work will include more granular inputs for individual drugs, drug doses, and more covariates such as comorbid conditions. We aim to include AKI at longer horizons of up to a week, and other adverse outcomes such as liver injury. Finally, the causal inference method is able to probe multi-way DDIs, which we will study further. Thank you from Team 11, DIGNIF.AI.